extremity edema, non-reducing right-sided varicocele. If it is systemic spread, then you will have system-specific symptoms like persistent cough, bone pain, cervical lymphadenopathy, constitutional syndrome. So something about paraneoplastic syndrome. So found in about 30% of patients with symptomatic RCC. So what are the things that we can find in their labs? Elevated ESR. They can be hypertensive. There'll be anemia, weight loss, cachexia, fever, abnormal liver function. So this is attributed to Stauffer syndrome. It is non-metastatic liver disorder where there is altered liver function in which is seen as elevated bilirubin, altered enzymes. This can be after nephrectomy. This comes down or it gets auto-corrected. The only lab abnormality that doesn't get auto-corrected is hypercalcemia. So in labs you will find anemia or polycythemia. You will find hypercalcemia. You will find elevated ESR. So the patient will be cachexic. He will have neuropathy, amyloidosis, or he'll have pyrexia. So by pathology, the different histological types are clear cell and non-clear cell. So the non-clear cell variety, clear cell, it's associated with von Hippel-Lindau familial syndrome where there is deletion of 3p chromosome. So this is asked as a question. This in detail about the mutation, presentation and genetic screening I'll be telling a little later. So the other forms are papillary, type 1 and type 2, then chromophobe, unclassified, acquired cystic associated renal carcinoma, bile duct carcinoma, hereditary leiomyomatosis, where there will be cutaneous and uterine leiomyomas, MIT family translocation, mucinous tubular, multilocular cystic clear, or post-neuroblastic RCC, medullary, or SDH associated or tubulocystic. So a note on the newer molecular defined RCC variety. So I remember this as CFAT. So the entity, the first letter of this entity and its mutation resemble each other except for eosinophilic solid cystic. So S is for SMARC RCB, SMARC B1. It is SMARC B1 deficient. So there is loss of SMARC B1. So that is S. E is eosinophilic solid cystic RCC. So it is tubular sclerosis associated mutation or mTOR pathway mutation. Another C is ELOC mutation. F for fumarate hydrate deficient RCC, which is deficient or there is mutation of FH. A is associated with ALK rearrangement. So there is ALK mutation. T is TFEB alteration RCC. So it is CFAT. Basically, these have typical characteristics. I don't think we can remember. We can just, only remember in case they are, because they're asking molecular classification and this is a new entity proposed by WHO. The International Society for Urological Pathology is given 4 grades depending on the nuclear characteristic of RCC. So this is important in your staging as well. So grade 1 is nucleoli absent. From 2 to 4, the nuclei which is conspicuous and it is eosinophilic stain will become pleomorphic in grade 4. So differential and staging. Okay, when we have a suspected RCC. I'll just finish up the, First we'll see the staging, then we'll go into hereditary syndrome. I've just taken a table from Bailey and Love. So T1, T2, T3, T1 and T2 are differentiated by the size criteria. Less than 7 centimeter, more than 7. Again, it is divided into A and B depending on cutoff of 4 centimeter. 7 is again divided by cutoff of 10 centimeter. So 4 to 7 is T1A. Sorry, less than 4 is T1A, 4 to 7 is T1B. 7 to 10 is T2A, more than 10 is T2B. So these are organ confined diseases. From T3, there is vein involvement, there is perinephric, but gyrotous fascia is not breached. Ipsilateral adrenal gland is also involvement is not also not included. So T3 includes vein and perinephric involvement. Here again, the vein involvement is again subcategorized as ABC, where the tumor extend into the renal vein and segmental into the pelvic calyceal system, not beyond the gyrotous fascia. Once it gets into the IVC, it is divided into B and C, where it is below the diaphragm and above the diaphragm. The Nevis or the Mayo classification again divides this into four types that we will see later, because there is a question on management of IVC thrombus also. So when it invades gyrotous fascia or contagious extension into the adrenal gland, it is T4. So any regional nodal involvement is N1. So stage 1 is T1, stage 2 is T2. In T3, it is T3 along with N1, all N1. 4 is T4 with M1. Here again, grade 1 to 4 are included. Then coming to hereditary syndrome. In the clear cell variety, that is the most common type. It can be sporadic as well. There's associated with 3p chromosome mutation. Papillary has two variety. I remember this is 1 and 2. This is good variety and not many associations. Here this is aggressive variety and there is association with pheochromocytoma. So, and this is the second one most common. There can be sporadic and familial type. Chromophobe has good prognosis, usually sporadic. Collecting duct is uncommon, aggressive, arises from the medulla, centrally located tumor. Renal medullary, it's a very rare, very aggressive, associated with sickle trait and younger individual and centrally located tumor. Coming to manifestation of this hereditary syndrome. So they've just asked hereditary syndromes associated with renal cell carcinoma. So clear cell is associated with von Hippel-Lindau, BAP1 mutation, and SDH associated renal cancer. This is genus VHL gene. It's a truncated protein where 3p is mutated. It's seen in incidence of 25 to 45%. Here there are two major and minor criteria. The major ones are renal cell carcinoma. I remember that CVHL. So from I you have to start all the hemangioblastoma from retina, spinal cord, cerebellum, and pheochromo. So kidney, adrenal, and start from retina. So these are the manifestation and they form the major criteria. In the minor, start as auditory. So inner ear disorders and cysts in the pancreas, renal cysts, ovarian cyst adenoma, epidermal cysts. So all the cysts in the genital and the reproductive organs constitute minor criteria. These manifest even in childhood, so your screening usually starts in infancy. You're in ophthalmoscopy or audiometry. All the imaging for pheochromocytoma and RCC begin at 11 years. So when we go through the NCCN, we'll just see the guidelines for screening. BAP mutated disease, also known as tumor predisposition disease. Its association with BAP1 gene, BRCA associated protein. Here, because it's BRCA associated, breast cancer association, melanoma, mesothelioma, and melanocytic tumors. SDH associated is SDHBCD. It is succinate dehydrogenase, subunits of BCD. As we had already studied, paraganglioma, carotid pheochroma, and all these neuro and cells origin tumors with GIST. So non-epithelial malignancies you have to remember. Papillary itself has hereditary type 1 and 2. Hereditary leiomyomatosis is also papillary associated, where there is fumarate dehydrogenase deficiency. Since it has got two letters, it is type 2. It is associated with alteration of fumarate hydratase. So there are leiomyomas in the uterus, in the skin, and it is associated with breast and bladder cancer. Hereditary papillary kidney cancer is associated with MET is type 1. It has got there is alteration of hepatocyte growth factor receptor, and there is no additional feature. Multiple types of tumors is associated with Bridhock-Dubé, tuberous sclerosis, Cowden, and parathyroidism jaw tumor syndrome. So Bridhock-Dubé is folliculin in alteration is seen in FLCN. There are fibrofolliculomas and trichodiscomas, pulmonary cysts, and pneumothorax. So they have a predilection for spontaneous pneumothorax. Tuberous sclerosis complex. There are two, TSC1, TSC2, hamartin and tuberin alteration. There are brain-associated malignancies like subependymomal giant cell astrocytomas. Coming to the face, there's angiofibroma. Then in the fingers, there's ungual or periungual fibroma, forehead plaques, cardiac connective, and angiomyolipoma. In Cowden, it is P10, it is phosphatase tensin homolog. So there are associated malignancy of breast, endometrium, thyroid, macrocephaly, intestinal hematomas, multiple skin manifestations. In hyperparathyroidism jaw tumor syndrome, it is parafibromin. Associations are parathyroid carcinoma, hyperparathyroidism, job fibromas, parathyroid gland tumors, and renal cyst and uterine carcinomas. So this table is something that you have to by heart and write. Non-clear cell association, again they've
tomorrow पेन एंड पैलिएटिव ऑन्कोलॉजी की क्लास है, मतलब पेन एंड पैलिएटिव का क्वेश्चन आएगा.
When is that class?
सैटरडे मॉर्निंग, जो हमारा यूजुअल रहता है.
Okay. So anyway, papillary. So von Hippel-Lindau is associated with chromosome 3p abnormality. So remember this diagram. This is the unit of VHL. When it is mutated, only this we'll have to remember, this one. So VHL gene mutation. So there is disruption of the functioning of VHL, where there is increased expression of hypoxia-induced factor 1 alpha. That will cause increase in VEGF, so increase angiogenesis, and that is why they are very vascular tumors. GLUT1 dysregulation, so there will be metabolic dysregulations, and PDGF leading to autocrine growth stimulation. Then coming to, so this is about the hereditary syndrome. So in hereditary syndromes, you'll have to write, they usually will be multiple and there'll be associated features. There is need for genetic screening, counseling, and surveillance for other disorders, and what are the mutations associated. So there are therapeutic implications, surgical and systemic therapy also. So in multiple tumors prone to hereditary syndrome, so your nephron sparing surgery is of importance. And then systemic therapy choices also, platinum sensitivity and targeted therapy are specific to some hereditary syndrome. That is one other thing. So now coming to small renal masses. So it is incidentally detected, or where small renal masses are clinically localized cortical tumors up to 4 centimeter in size. So same, what are the modalities that you can adopt to manage them is, it can be surgical, radical or partial, it can be open or with minimally invasive, and other local directed therapy like thermal ablation, and you can resort to even active surveillance. So when you get a patient suspicious of renal mass, you'll take history, physical examination, you'll take their family history, you'll see their blood, especially in metastatic disease. You will need to risk stratify this patient by MSKCC criteria or Heng et al. Criteria. Urine analysis, excuse me, abdomen, pelvis, CT, rule out other imaging modality to rule out metastasis, and symptom-oriented workup, bone scan, brain MRI. Then if urothelial tumor is suspected, that is especially central location, then you have to do cytology. Then counseling and genetic evaluation for multiple renal masses, presentation less than 46 years. Then in stage 1A, that is less than 4 centimeter. We have 4 modalities. Up till your stage 1, you can use all these 4 modalities. Beyond, once it becomes more than 7 centimeter, then your role of active surveillance won't be there. Mostly it is surgical. So in stage 2, 3, you will resort to partial or radical nephrectomy. Then followed clear histology usually will have good prognosis and only surveillance will be advocated. You will use adjuvant pembrolizumab for grade 4 tumors. If it is clear cell, only with grade 4 tumors.
इसमें ग्रेड
and
4
those with
ग्रेड 4 को तो
sarcomatoid
सार्कोमेटॉइड बोलते हैं ना. इसकी जो ग्रेडिंग होती है उसमें ग्रेड 4 इटसेल्फ इज अ सार्कोमेटॉइड ना.
No, nuclear grading is grade 4. Sarcoma features is on gross.
तुम्हारा वो वाला स्लाइड पे
cytologically
एक बार लेके जाओ जिसमें
different.
तुमने स्टेजिंग पढ़ाया था. ग्रेड 4 इज
nuclear
द
pleomorphism and or
जहाँ तक मुझे याद था सार्कोमेटॉइड एंड मल्टी न्यूक्लियर जाइंट सेल एंड रैप्टॉइड. तो नॉर्मली सब में ग्रेड 3 होता है. ग्रेड 4 जो होता है वो सिर्फ आरसीसी में होता है.
हाँ
मैं बोल रही हूँ कि दे आर इन मोस्टली सब में ग्रेड 3 होता है एक्सेप्ट फ्यू कंडीशंस. जैसे कि एक तो इसमें ग्रेड 4 होता है, एक आई थिंक सार्कोमा में ग्रेड 4 होता है. वो FNCLC जो ग्रेडिंग है उसमें. इसका जो ग्रेड 1 है इसको 400 मैग्निफिकेशन में हम देखते हैं और उसमें न्यूक्लियोलाई वगैरह कुछ नहीं मिलते हैं. ठीक है. 4 और ग्रेड 2 में 400 मैग्निफिकेशन में आपको कॉन्स्पिक्यूअस एंड इसोफेनिक न्यूक्लियाई मिल रहे हैं बट 100x में नहीं मिल रहे हैं. ग्रेड 3 में 100x में भी यू आर गेटिंग न्यूक्लियाई कॉन्स्पिक्यूअस एंड इसोफेनिक मैग्निफिकेशन, दैट इज ग्रेड 3. एंड इसके बाद नहीं 10x या नॉर्मल में भी मार्क न्यूक्लियर प्लियोमॉर्फिज्म दिख जाता है तो वो ग्रेड 4 होता है विथ मल्टी न्यूक्लियर जाइंट सेल्स, रैप्टॉइड एंड सार्कोमेटॉइड.
it can be individually with multinucleate or rhabdoid or sarcomatoid difference.
तो तुमने बोला नीचे कि ग्रेड 4 है तब हमको या सार्कोमेटॉइड डिफरेंशिएशन है तब हमको एडजुवेंट देना है.
For clear or non-clear cell in stage 2, you will not give until it is grade 4 even with clear cell sarcomatoid. In stage 3, you will usually prefer to give adjuvant pembrolizumab.
नॉन क्लियर को सर्विलेंस करना है, क्लियर सेल में हाई रिस्क फीचर्स है तब हमको एडजुवेंट पेम्ब्रोलिजुमैब देना है. इसका ट्रायल पता है क्या क्या है पेम्ब्रोलिजुमैब का?
562 I put no keynote 562.
562 ठीक है.
So keynote 562. Okay. Now in stage 4, unlike other places, here there is role for cytoreductive surgery.
स्टेज 3 में नोट पॉजिटिव आया था ना सहाना ऊपर. स्टेज 3 में N1 आया था. तो इसमें N1 आया है तो इसका मतलब ये नहीं है कि हर पेशेंट को हमको न्यू एडजुवेंट इम्यूनोथेरेपी देनी है. हमारे ट्यूमर बोर्ड वाले बहुत पंगा करते हैं. तो इफ़ नोडल थोड़ा पॉजिटिव भी है, रीजनल नोट्स अगर पॉजिटिव भी है तो इसने ये 0 to 20 0 to 10 क्या लिखा है? ये N1 0 to 20 क्या है बगल में? ठीक है, होगा कुछ, चलो जाना।
सर्वाइवल।
तो नोट पॉजिटिव पेशेंट को नियो एडजुवेंट थेरेपी का कॉन्सेप्ट नहीं है, ये मेरा बोलने का मतलब है अकॉर्डिंग टू NCCN।
Correct. There is no role for neoadjuvant. And even in enlarged image positive or introp enlarged, only then you will do lymphadenectomy. Only prognostic implication, no therapeutic benefit. It just tells that the tumor is aggressive. There is a line for that here.
स्टेज 3 में हम लोग करेंगे ना प्रोफाइलैक्टिक lymph node dissection 2 and
I see here. Okay. See, when there is clinically N plus, these finding lymph node plays an important role in diagnostic rather therapeutic tool. Practically, the decision to perform LND should be taken with caution and considered in younger and fumate hydrous papillary type 2 and consideration of adjuvant where there is no benefit in added procedure but subjected to lower real risk of associated complications. So it's basically for prognostic. So when you see enlarged nodes like stage 3, yes, you have to do, but it's not for your therapeutic advantage. So only two indications are image picked up positive nodes or intraoperative enlarged nodes.
Okay.
Okay.
यार वो टाटा वाली किताब में तो लिखा है कि enlarged nodes तो it also says that anywhere you see enlarged nodes you do it, but the Tata वाली book says that clinically T3 T4 disease and positive में तो करने है, but clinically T3 T4 disease also you have to do lymphadenectomy. I'll share the screenshot. I don't know.
That I read it was not mentioned.
I read the same thing what you just told, na, that it has no therapeutic effect. It has only prognostic effect. But Tata book has this flow chart. It shows that in node positive clinically we have to do T3 T4 also we have to do. So I'll share the screenshot. If somebody has if you have a better data for it, then we can probably.
Okay.
यार मुझे लगता है कि ये जो थोड़े सब्जेक्ट्स हैं जिसमें हम लोग को थोड़ा कम प्रैक्टिकल नॉलेज है, उसमें कोई एक गाइडलाइन फॉलो करके लाइफ में आगे बढ़ते हैं, एग्ज़ाम में लिखने लायक कॉन्सेप्ट बना लेते हैं। यूरो इज़ लाइक वन ऑफ दैट कि जिसमें मेरे को प्रैक्टिकल नॉलेज उतना नहीं है।
Okay, let me see if I can find out that answer for you. Okay, next going to so adjuvant is given beyond stage 2, especially in only sarcomatoid differentiation or grade 4 clear cell and stage 3 clear cell. Otherwise, it's just surveillance after it. Coming to stage 4, it can be T4 or M1. In T4 resectable, you will do nephrectomy and you will give adjuvant only in clear cell. Otherwise, it's surveillance. In unresectable, you will do all that molecular biology and all that and resort to systemic therapy. Here, there is role for cytoreductive nephrectomy. So, management of M1, you have potentially surgically resectable primary with metastasis. So here there is role for cytoreductive surgery, especially it should be done in good performance status patient, selected good performance status patient only. Otherwise you have to resort to systemic therapy. Here in systemic therapy you will divide them into clear cell non-clear cell with favorable or unfavorable histology. And as to how to choose, we will go in when we see our subsequent slides. So to summarize, stage 1, stage 2, stage 3, stage 4. In 1 and 2, there are 4 therapies. Basically, all are directed towards loco-regional treatment. NSS, radical nephrectomy, your thermal ablation, and surveillance, active surveillance. The concept of active surveillance here is small renal masses, 20% of them are benign. So they found that it was over treatment by even doing nephron sparing surgery because there is risk of chronic kidney disease with any form of surgery. Even if it is NSS, there is chance of patient going to CKD later. Then they found that with active surveillance, when you found the patient, they still were operable, or if it was metastatic, they did not find any overall survival difference. So in small renal masses, active surveillance is advocated. Disadvantages, you really don't know the biology of the disease. You're just you're taking it by size and you're managing it by active surveillance. You really don't know who progress and who don't. And even the patient has to be apprehensive and they have to keep following, and there'll be unnecessary radiation associated imaging. Next, stage 3. Here, loco-regional treatment with adjuvant is advocated. Here again, adjuvant treatment in clear cell grade 4. In stage 3, there is loco-regional treatment like nephrectomy with adjuvant treatment. Pembrolizumab only in clear cell. Rest everything is surveillance. In stage 4, you will see whether it is T4 or M1, and there is role for cytoreductive surgery. And this is for ascopal effect, where treatment of primary will cause disappearances of secondaries. That is one thing. Second, the 2 trials that we have to know is Carmina and Certime trial, along with cytoreductive surgeries. Now, with development of good targeted agents, the role for cytoreductive surgery is actually coming down because there is association of morbidity and mortality as high as 10%. That is one thing. Most of the time, metastatic patients have a poor performance state, and not all of them will be surgical candidates. And a point to remember in thermal ablation is you have to do biopsy prior thermal ablation.
स्टेज 4 में तुमको डायरेक्ट सर्जरी करना है कि इम्यूनोथेरेपी पहले देना है?
See, there is targeted therapy is the primary therapy, but they said that you can place your cytoreductive surgery before or after it. This is not. This is just to debulk, and the tumor load will be decreased so that the target agent has a better response. That is the concept, but that we will be studying when we go through cytoreductive surgery, because that is also a question. Then when we are coming with evidences for these local treatment, here when we are talking about partial nephrectomy, what are all the things that we'll have to know? In partial nephrectomy, you are sparing some nephrons, so you will be preserving the patient's renal function. So whom is it advocated? So those who have solitary functioning kidney, who have multiple tumors bilateral, those who are CKD patients, hypertensive, those who have increased renal morbidity. In them, it is indicated. There is a where is it? Okay, the indications are bilateral RCC, RCC in solitary functioning kidney, unilateral RCC with opposite functioning kidney affected by these comorbidities like renal artery stenosis, then chronic pyelonephritis and all ureter related problems, calculi, diabetes, nephrosclerosis. Then what is the goal? First, you should be giving an oncologically safe surgery where you will be decreasing the local recurrence. Then you will preserve the function of the kidney. What are the 2 things that you will be taking care is the operative time and the warm ischemia time. This is a standard of care for less than 4 centimeter tumor, but there is extended criteria. You can go beyond, where tumor size is not just the only thing that you will be considering. It's the complexity and its relation with the pole, and its distance from, whether it is more predominantly cortical or medullary, all that you'll have to see. What is the rate of local recurrence? It is 3 to 5%. Only when partial nephrectomy is not feasible, then you will have to resort to any renal supplementary procedures like dialysis or renal transplant. The trial of TKIs to downside tumor and enable partial nephrectomy has been advocated, but it's not proven benefit. So, what are the determinants of renal function after partial nephrectomy? It is the pre-surgery quality of parenchyma, and how fast you did the surgery, and what was the warm ischemia time. What are the evidences? Okay, so this is the advantage. The disadvantage is that there is increased recurrence rate. Here, the margin positivity rate is also high, and this can be done for less than 4, and they say size is not an absolute criteria. It's a complexity of the tumor. While then about thermal ablation, it's a kidney sparing approach where renal function benefits are there versus radical nephrectomy. It is outpatient procedure, usually preferred for less than 3 centimeter in patients who are a poor surgical candidate and have a less renal reserve. Here they have high rate of local recurrences disadvantage, imprecision histopathology, and radiological follow-up can be really challenging. Then active surveillance, least invasive, most kidney sparing of all strategy. Most small renal masses have limited oncologic potential, and they are safe because they are managed with short interval follow-up with imaging. Intensity is depending on the tumor and the patient characteristic. Here the disadvantages, there is no shrinkage, it still remains the same, and here there is no biopsy, so biology is not known. Usually it is adopted for patients with less life expectancy or poor surgical candidates. The same is repeated in this paragraph as well. So nephrometry scores. Okay, some evidences for partial nephrectomy. Here, less than 4 centimeter, the local recurrences are in single digit 1 to 2%. This is given by AUA meta-analysis by Campbell et al. Patients with less than 4 centimeter or up to even 7 centimeter, their oncological safety was preserved. One, in terms of local recurrence, cancer-specific survival, and only thin rim of margin was enough. The contralateral metachronous lesions are also 1 to 5%. So what are the 3 things that you'll have to mention? Oncological safety and renal function. Oncological safety in terms of local recurrence, cancer-specific survival, and margin, only minimal width is enough. And you have to quote this Campbell et al., which is a meta-analysis. Then, okay, to know the complexity of the surgery, partial nephrectomy, there are some renometry scores that will tell you the location, size, and their relation with the pelvic calcium system, so that you will know prior what is the complexity of the procedure, what will be your time of surgery, how well you can preserve the parenchyma, what is the chances that you will end up doing radical nephrectomy. So I've written 4 scores here. Renal nephrometry score, you can broaden it. R represents a radius, E for endophytic or exophytic, N is nearness to the collecting system or sinus, anterior or posterior, location with respect to the polar lens. There is a modified Padua score, C index score. Padua, I forgot to add. I'll send it later then. C index is the score assesses the relationship the tumor with the kidney center. The central the tumor, more complex will be a nephron sparing surgery. Arterial based complexity score, ABC, is depending on the vascular anatomy. This score helps us knowing the surgical complexity, risk of complication, whether the patient will really end up having partial or will end up having radical nephrectomy. Then coming to stage 3, so invasion of the tumor thrombus into the vein. So here we'll mention one, the NCCN classification, where the T3 is divided into A, B, C, where the thrombus is in the renal vein and the segmental veins. BC, it is IVC, above the diaphragm or below the diaphragm. Nevis classification or Mayo classification starts with 0 to 4, and your management subsequently depends on how you the vascular control. So they've asked us to even elaborate the surgical management in IVC thrombus. So when the thrombus is in the renal vein, only confined to here and not extending, then you'll resort to radical nephrectomy here. If you just get vascular control with the C clamp here, it is more than enough. No need to take control of the opposite renal vein. That is with level 0. Coming to level 1, you'll here you'll have to take control of the contralateral renal vein. You'll clamp it, and you will take controls of the proximal and distal IVC here. In level 3, so the level 3 is, it's in the IVC. Level 2. Level 2 is below the hepatic veins, but it is with above 2 centimeter from the renal vein. So first let us define 1, 2, 3 and 4. It is in the renal vein. 1 is in the IVC, 2 centimeter, within 2 centimeter from the renal vein. So it is within 2 centimeter of the renal vein. If it is above 2 centimeter, it is 3. No, sorry. 1 is within 2 centimeter, 2. This is 3, yeah. More than 2 centimeter is 2. 3 is with respect to whether it is below the hepatic veins and below the diaphragm. 4 is above the diaphragm. So for your 2 and 3, you will need hepatic mobilization.
देखो मैं एक बार बताती हूँ, 0 अप टू रीनल वेन, 1 2 सेंटीमीटर, ठीक है. 2 अप टू लोअर बॉर्डर ऑफ लिवर, मतलब इंफ्रा हेपेटिक 2, and 3 from intrahepatic portion of liver of IVC up to below diaphragm, and 4 above diaphragm. हो गया, इतना ही है.
So the 3 landmarks that you'll have to remember is, 1 is 2 centimeter cut off, 1 hepatic vein and diaphragm. Anything above diaphragm is 4. If it is in the renal vein, it is only 1. Then you'll have 1, 2, 3. So 3 will be hepatic vein to diaphragm, between hepatic vein to 2 centimeters. Okay.
तो हमको 4 वाले के लिए कार्डियोवास्कुलर सर्जन चाहिए रहता है. 4 से नीचे हम लोग ऑन्को सर्जन भी ऑपरेट कर सकते हैं.
So level 0 is without contralateral control. Level 1 is you'll need contralateral control and proximal and distal controls. In level 2 and 3, you will need a hepatic surgeon. In level 2, you'll just have to mobilize the liver and take control of just mobilization is enough. Whereas in 3, you'll have to take outflow controls of caudate, where you will ligate and you will separate and you will totally mobilize the liver so that you will get good delineation and freeing IVC, so that you will get proximal and distal controls. In 4, you will need a cardiopulmonary bypass with hypothermic cardioplegia. Here the thrombus is extracted from the right atrium. So Satka, he just described 3 things where the complexity of vascular reconstructions can be anticipated if it's a right-sided thrombus, if the AP diameter of the IVC at the renal ostia is more than 3.5 centimeter and complete occlusion of IVC. So there is the role of neoadjuvant treatment in order to shrink thrombus is ineffective. In palliative setting, you can use SBRT. So the others ones are Novick, Hinman, and Robson. Adjuvant, we studied this is over. Okay. Previously, there was role for TKIs in adjuvant setting, that is sunitinib, sorafenib, all of this post resection, but now it is only pembrolizumab that is advocated. So if you want to mention, you can mention about sorafenib versus sunitinib assured trial, sorafenib source, and STRAC versus placebo. These are old. So the one that we are using is, I told 562, it's 564. Keynote 564, adjuvant pembrolizumab. And there is role for nivolumab and durvalumab, where the results are still awaited. Here, pembrolizumab adjuvant in clear grade 4 and stage 3 is there is improved DFS. So most of the patients do present with metastasis, that is about 30 to 40%. So there are some trials which will support cytoreductive surgery, and there are some negative and some are non-inferiority trials. So initially 3 trials RCTs were conducted to see the benefit of cytoreductive surgery with interferon. So the survival data, they had a difference of about 5 months when they underwent surgery with interferons alpha. So this is old. Now no longer interferon alpha is advocated. So initial trials with comparing 2 arms, surgery plus interferon alpha and interferon alpha alone. This had about 5 months benefit. Then came the newer 2 RCTs launched in 2009 and 2010. So one, they wanted to see if cytoreductive surgery really worked, and they wanted to see the sequence of targeted therapy used along with cytoreduction. So Carmina patients were randomized to upfront nephrectomy followed by sunitinib versus sunitinib alone. In certain, sunitinib was given prior to nephrectomy or after nephrectomy. So those two were the arms. So certain, that is the sequence of targeted therapy, actually had no effect on DFS, but a benefit of OS was seen in those where cytoreductive nephrectomy deferred group. So telling that there was no need for cytoreductive surgery. In Carmina trial, it was a non-inferiority trial to say that sunitinib alone is enough, questioning the use of cytoreductive surgery. So Carmina and Satyev did not support cytoreductive surgery, telling that targeted alone is enough for DFS and OS benefit. But there were some smaller phase 2 trials like Polis, which demonstrated some advantage of cytoreductive nephrectomy. So when we are quoting, we can quote pre-TKI era, that is surgery done along with your interferon treatment, where 3 RCTs, and they said cytoreductive nephrectomy with interferon alpha is definitely better. Coming to TKI era, where sunitinib was chosen, one arm had surgery with TKI, another had only TKI. There, they did not prove any benefit of adding cytoreductive nephrectomy. Then coming to certain, where both the arms did contain surgery, but the timing of neoadjuvant or adjuvant sunitinib was tested. Here, the only benefit was seen where patients who did not undergo nephrectomy had some benefits with only TKI. The positive trial you can quote is phase 2 smaller phase 2 trial by Paulus, telling that cytoreductive nephrectomy added to advantage in DFS. Finally, to tell, we have to conclude that cytoreductive nephrectomy has to be done in selected patients who have good performance status less than or zero equal to 2, and whose metastatic burden is not much, and those who are brain metastasis free. In them, you can resort to do cytoreductive nephrectomy. Since the newer generation of immunotherapy and combination of TKI have been proved superior, now people don't resort to cytoreductive nephrectomy. Coming to metastatic disease, the question asked here is only about targeted therapy. To know, we should know the risk prognostic model proposed by MSKCC. Here, the interval from diagnosis to treatment is less than 1 year. Their performance status is less than 80%. LDH greater than 1.5 times the normal, calcium, and hemoglobin. So, lab parameters are HB, calcium, LDH. And when you take history, their performance status, and from their diagnosis to when they reached for treatment, if it is less than 1 year. None of these prognostic factors are present, then it is low group. 1 or 2 comes to intermediate, poor is 3 or more. Heng et al. IMDC criteria. Here, lab parameters are hemoglobin, calcium, like previous. The 2 extras are neutrophils and platelets, performance status, and the diagnosis to treatment less than 1 year. The 2 extras here is neutrophils and platelets, and LDH is not a part of IMDC. Here, same favorable, intermediate, and poor. So IMDC had favorable instead of low group. So no prognostic factors were favorable. 1 to 2 is intermediate and 3 to 6 is poor.
एक मिनट दिखाना ऊपर.
Then while you are
एक मिनट
writing
दिखाना वो
targeted
ऊपर
therapy,
वो risk factors. कुछ तो उस दिन हमने अवनीत कुछ तो हमने उसका कुछ ट्रिक बनाया था ना.
हम सोच रहे थे कि इंटरनेशनल वाले बहुत खुदम खादी करते हैं, तो फिर उन लोगों ने न्यूट्रोफिल्स और वो भी वो किया था, और कुछ हिप करके किया था. हिप में कुछ
हिप
में
हीमोग्लोबिन परफॉर्मेंस स्टेटस, आई से इंटरवल. आई से इंटरवल.
हिप दोनों में कॉमन था. हीमोग्लोबिन इंटरवल और परफॉर्मेंस स्टेटस कॉमन था, और कैल्शियम में उसमें
कैल्शियम दोनों में कॉमन है. कैल्शियम हिप को अच्छा स्ट्रॉन्ग करने के लिए कैल्शियम चाहिए ना, तो कैल्शियम दोनों में कॉमन है और हिप है. उसके बाद इंटरनेशनल वालों में बहुत ज़्यादा डिटेल स्टडी करते हैं, इसलिए न्यूट्रोफिल्स एंड प्लेटलेट्स देखते हैं, और LDH MSKCC वाले देखेंगे. ठीक है, कुछ ऐसा निमोनिक करके याद रखेंगे तभी तो याद होगा, वरना याद नहीं होगा. ठीक है.
Okay, to write about
हाँ बोलो.
Role of cytoreductive surgery, उसमें what did you say कि before the TKI area we mentioned 3 trials.
Certain Carolina.
Which were those 3?
Before TKI, 3 trials. Those are 3 randomized, which demonstrated survival benefit of adding cytoreductive surgery to interferons. Then came TKI era. In TKI era, it was Carmina and Certine.
Carmina there is no need. Okay.
Both said there is no need. In Certine, it is time. It is only the sequence of TKI before or after. That's
So उसमें भी Certine the effect on OS was seen only in those in which cytoreductive nephrectomy was deferred.
It was not done.
तो both said the same.
Yeah. And there were smaller studies which proved cytoreductive surgery is better, like in small phase 2 trials. So that you can mention this Paulus et al.
कौन सा et al?
Paulus, POWLES, Paulus et al. So after knowing in metastatic, you will know whether these are favorable, intermediate, or poor risk people. Then for options. So what are the options available? Cytokines, TKI, immunotherapy, TKI plus immunotherapy. So the older era was cytokine, that is interferon alpha and IL-2. Now we are not using this. Then all that capillary leak syndrome, and there were a lot of toxicity. Now we have got better regimens and better targets. Then comes TKI. So what all constitutes TKI? That the basket of drugs are sunitinib. Oh God, what is this? Sunitinib. If you compare sunitinib to interferon, it's sutentriol. Interferon, ENT or INT, interferon, it is sutentriol. If you compare sunitinib with cabozantinib, it is capusan. Capusan trial, if you remember. With pasopanib, it is Compras. Then the other drugs are pasopanib, cabozantinib, bevacizumab, mTOR, temsirolimus, everolimus. So this is what I've summarized there. In Sutent, it is sunitinib with interferon. Caposan, it is cap is cabozantinib. With sun, it is sunitinib. Compras, it's comparing pasopanib with sunitinib. So these are the important trials that we have mentioned with this. The other drugs are it's used in combination or alone. Then coming to the next question. Next is the immunotherapy era. When immunotherapy came, it was not given singular. It was given in combination with TKI or immunotherapy with immunotherapy. This is the new era. Immunotherapy with immunotherapy. Drawback with immunotherapy was there was lot of immunotherapy related adverse events. So that is the drawback. So coming to immunotherapy with TKI. Axitinib is the TKI that is used with, if it is used with pembrolizumab, it is keynote 456. Wait, I have it here. Yeah, 426. Axitinib with pembrolizumab versus your TKI, it is keynote 426. If it is axitinib with avelumab, so in combination, the TKI of choice is not sunitinib, it is axitinib. With immunotherapy, that is pembrolizumab and avelumab. So if the combination, so the backbone of TKI is axitinib, and if you use pembrolizumab, it is 426. If you use avelumab, it is javelin. Javelin is avelumab. The new one is Nivi-Ipi Checkmate 314. So what is the rationale in combining immunotherapy with TKI? VEGF TKIs are anti-angiogenic. They even block the growth receptors as well as they are immunomodulatory. They increase the immune cell infiltration and they decrease the immune suppression. So these are the preferred category 1 recommendation by NCCN. So clear cell histology. So here everywhere it is actually IO plus TKI that are category 1 recommendation. The TKI backbone is axitinib, IO is pembrolizumab or avelumab. So in favorable risk, this is what we use. In poor or intermediate risk, it is the same category, not much of difference. If you want to remember second one, then it is cabozantinib with nivolumab. don't think I'll be able to remember. So backbone of axitinib with pembrolizumab or avelumab, you can remember.
कैटेगरी 1 याद कर लो, अदर रिकमेंडेशंस पे मत जाओ, कैटेगरी 1 सिर्फ देख लो. तो अगर फेवरेबल प्रोग्नोसिस है तो एक्सिटिनिब एंड पेम्ब्रोलिजुमैब, कैबोसिटिनिब एंड निवोलुमैब, लेनवाटिनिब एंड पेम्ब्रोलिजुमैब. इसमें से सिर्फ एक कॉम्बिनेशन नया है नीचे, बाकी सब सेम है. लेनवाटिनिब अकेला सिंगल कैबोसिटिनिब भी दे सकते हैं प्रिफर्ड रेजिमेन.
TKs. So the order of therapy is, the newer one is you combine IO with TKI. That is better than TKI. If the patient has no money, they have lot of immune related complications, then you can give only TKI. So what are the individual TKI? You can use the traditional sunitinib, pasopanib, cabozantinib, all of that. So same here. If there is recurrence with already tried prior therapy, then you can use single agent TKIs. If they are IO naive, then the same combinations or individual drugs can be given. These are all for relapse, subsequent relapse. Those for non-clear cell histology, here there is actually not proven benefit of any one drug. So they're all in still clinical trials. So here you can give single agents or in combination. Here you can even add all your targeted like BEV to it. Erlotinib with BEV, you can remember, especially in hereditary leiomyomatosis. This one thing you can remember.
I think lenvatinib plus pembrolizumab is common to all. क्या जरा एक बार देखना ऊपर तक. ये cabozantinib and nivolumab is also common to all. ऊपर और ऊपर जाओ.
One more thing that you can remember is cabozantinib with
nivolumab. हाँ वही मेरे को लग रहा है. cabozantinib फिर nivolumab is common to all and pembrolizumab plus lenvatinib भी. ऊपर देखना एक बार क्लियर सेल वाले में. हाँ, lenvatinib plus pembrolizumab and cabozantinib plus nivolumab is common to all histologies, all varieties.
So your targeted therapy also, you can put that VHL diagram where even all that antiogenic PDGF and all can be added. In renal only, these are the questions that have been asked.
आज ना renal और bladder.
I'm going to bladder.
It will get too much.
हाँ?
क्या हुआ?
मैं कह रहा आज renal और bladder करते हैं.
What Divyang? You are not audible.
Hello.
हाँ.
मैं कह रहा आज renal bladder करते हैं. Renal bladder plus prostate will get too much.
5 organs है पर तो पहले ब्लैडर को फिनिश करते हैं, देखते हैं कैसा स्टेटस दिमाग का.
नहीं मतलब हाँ वही ठीक.
आई थिंक उसके अगर ब्लैडर प्रोस्टेट के अलावा यू कैन कवर टेस्टिस एंड पेनिस तो वो थोड़ा ठीक रहेगा. प्रोस्टेट इटसेल्फ इज अ वेरी बिग टॉपिक.
No, but questions are not many in prostate. It is only PSA, specific markers of screening, and RARP only. Not much. Prostate, they have not asked much. Maximum they have asked is testis, then bladder.
Testis and penis.
Testis बहुत पूछा है. Testis, kidney और bladder.
ठीक है, कोई नहीं. bladder
prostate they have not asked.
तो बचता क्या है आज? ब्लैडर के बाद क्या क्या बचता है? प्रोस्टेट बचता है, पेनिस बचता है, टेस्टिस बचता है.
प्रोस्टेट हाँ, we can cover tomorrow also.
मतलब all three can be done tomorrow because tomorrow the main topic will be testis. Testis को समझना थोड़ा मुश्किल है for medical oncology point. अपना काम तो बहुत छोटा है.
Oncology more common in males, smokers, alcoholic. Then what you have to know is chemical exposure, chronic exposure to dyes, and those people who are exposed to who work in chemical industries, rubbers. So, chemical exposure, smoking, chemical and chronic condition like irritation, catheters, cystosomium, hematobium, irradiation, all that. But this is not asked. In case you want to know, that's all. So smoking is a risk factor. Chemicals, all that aromatic hydrocarbons, aniline dyes, nitrates, nitrites, rubber, plastic, tal industry, Balkan nephropathy, cyclophosphamide, which causes cystitis. So, no association has been found with the beverages, and protective antioxidant selenium and vitamin A, C, E are protective.
ब्लैडर में क्या क्या क्वेश्चन आए हैं?
Cystosomia,
ब्लैडर में
hematobium,
क्या क्या क्वेश्चन आए हैं?
HPV. They've asked about BCG refractory management of BCG refractory disease, muscle invasive bladder cancer, bladder preservation techniques, and what else? Diversion, types of diversion and complications. So in pathology, in bladder, we can expect this molecular pathology. New one in bladder invasive malignancy, this molecular pathology is making sound recently. So WHO classification of bladder cancer. So by histology, it can be urothelial, squamous, glandular, urachal carcinoma, Mullerian type, neuroendocrine differentiation, melanocytic, mesenchymal, and miscellaneous. In urothelial, it can be infiltrative or it is non-invasive. Infiltrative type can be good varieties and bad variety. SMMS or SMS, double M. You can remember SS, sarcomatoid, micropapillary, microcystic, then other is signet cell, poorly differentiated clear cell. These are all bad variety. Nested can be large nested. In non-invasive, this is the spectrum. It starts as in situ non-invasive papillary carcinoma, which is low grade or high grade, papillary urothelial neoplasm with low malignant potential. In squamous, it can be pure, it can be verrucous or squamous cell papilloma. Glandular can be enteric type, mucinous or mixed. Urachal, Mullerian can be clear cell, endometrioid. Endocrine can be small cell, large cell, well differentiated, and paraganglioma. Melanocytic tumors and mesenchymal tumors. In molecular pathology, I had put one. Okay, there are 3 classifications: ECGA, MD Anderson, and all of them have formed a consensus 2023 guideline where they have broadly divided muscle invasive bladder cancer into luminal type. Luminal has 3: papillary, non-specific, infiltrated. The second one is basal squamous is 2, non-endocrine is 3. Then stromal rich and neuroendocrine like. See, what you'll have to remember is these 3 also have different ways of telling the same thing. So they broadly divided it into actually 4, where luminal, basal, basosquamous, neuroendocrine, and only in one of it extra stromal rich. So you can just mention there are 3 guidelines and you can broadly mention this. Luminal type, luminal has again 3 times: papillary, non-specific, infiltrative. Basal, basosquamous, endocrine, neuroendocrine, and stromal rich. This is just now coming to workup. So you will take here also germline testing is important, especially those who have family history of Lynch syndrome. younger age of onset. Then you will do cystoscopy. You will see their histology. You will in the histology biopsy, you will see how far is the infiltration, what is the grade, what is the size, cystoscopy findings of CIS, then additional abdominal imaging, added upper urinary tract system imaging. So in muscle invasive bladder cancer, yes, the upper urinary tract imaging is mandatory. So the incidence, if there is upper tract involvement, there is 50% chances that the bladder cancer can be there in them. On vice versa, if the bladder cancer is positive, there's about 5% that there will be associated upper urinary tract malignancy. So what are the additional imaging? Additional imaging will be specific to the symptoms, and in muscle invasive bladder cancer, you will do metastatic workup. So you will add a thoracic imaging extra, and depending on the symptoms, you will add CNS imaging. If you're resorting to give NACT, which are cisplatin based regimen, then you'll have to do your GFR. You will ask the patient, you will screen for smoking history and all, and you'll ask them for a smoking session. Next, how do we stage the disease? All these three types come under non-muscle invasive bladder cancer. So it is non-invasive papillary tumor, that is TA. This has low grade, high grade. It can be TIS, or it can be invasion up to lamina propria and not beyond. T2 is muscularis propria, again divided into inner half, outer half. T3 is perivesical, microscopic or macroscopic. T4 if the local pelvic organs like prostate, uterus and vagina in vicinity, that is a female genital organ involvement and male reproductive organ involvement is T4A, prostate, uterus, vagina. If it is going to the lateral extent, pelvic and abdominal wall, so all the walls are T4B, abdominal and pelvic wall. So what constitute the regional drainage? So nodes up till the bifurcation. Internal, external, where it is bifurcated into common iliac.
होप है ना, होप होप है ना, होप है ब्लैडर का.
It is regional.
रीजनल में होप आता है. क्या है? हाइपोगैस्ट्रिक, ऑब्ट्यूरेटर, प्रीसैक्रल,
Hypogastric obturate.
प्रीसैक्रल एंड
No,
एक्सटर्नल
presacral
इलिया.
is actually is not. In here, you will not go. The common iliac is non-regional. Your extent of dissection had become extended, not non-regional. I meant to say N2, N1, N2.
पर ऑब्ट्यूरेटर, ये जो होप वाले नोड्स होते हैं ये पेल्विक नोड्स में आते हैं, और ये पेल्विक नोड में अगर सिंगल नोड इन्वॉल्व है तो N1 है, अगर मोर देन सिंगल नोड इन्वॉल्व है तो N2 है, और कॉमन इलियक इटसेल्फ इज अ. तो इसमें एजेसीसी में पढ़ते हैं तो लिखते हैं कि पेल्विक नोड और एक्स्ट्रा पेल्विक नोड. तो ये प्राइमरी ड्रेनेज जो एरिया है ना, वो जो नोड्स हैं वो होप वाले नोड्स ही है.
So what you have to remember is common iliac one is N3. That's all you have to remember.
तो कॉमन इलियक इज N3. तो इफ़ कोई भी नोड पॉजिटिव है तो इसमें हमको नोड पॉजिटिव पेशेंट अगर हम सस्पेक्ट कर रहे हैं तो हम उसको NACT देते हैं, या फिर इसका जो ट्रिपल मोडालिटी मल्टी मोडालिटी ट्रीटमेंट है वो देते हैं. ठीक है. तो वो तो सब मसल इन्वेजिव में आई थिंक सब में ही वो ट्रीटमेंट जाता है ना. ऑल मसल इन्वेजिव ट्यूमर शुड गो फॉर NACT. आगे पढ़ाओगी तो आई थिंक आ जाएगा वो. तो जब भी व्हेन वी आर रीडिंग एनी स्टेजिंग ना, वी शुड कीप इन माइंड कि व्हाई वी आर रीडिंग ऑल दिस स्टेजिंग. कैसे स्टेजिंग से हमारा ट्रीटमेंट चेंज हो रहा है। जब वो माइंड में रखेंगे देन डेफिनेटली वी विल रिमेंबर कि क्या चल रहा है। तो इसमें ये जब अभी ब्लैडर है, ब्लैडर में T2 से मसल इन्वेजन शुरू होता है एंड T2 इज़ द मसल इन्वेजिव एंड नॉन मसल इन्वेजिव, 2 टाइप के ट्रीटमेंट चेंज होता है। और N1 अगर आ गया देन ऑल्सो स्टेज 3 है कि 4 है आई डोंट नो, बट N1 आ जाता है तो पेशेंट को NACT लगता है। तो NACT के क्या इंडिकेशन है, या तो मसल इन्वेजन हो जाए या नोड पॉजिटिव हो जाए, ठीक है। और मेटास्टेसिस तो दूर की बात है। गायत्री मैडम जिंदाबाद।
So beyond T2 N0, that is stage 2 and beyond. T1, T4, N1. So more than T2 and N plus. So you will resort to give neoadjuvant chemotherapy followed by radical cystectomy. The preferred regimen is dose dense MVAC, that is on Vesper trial. So what are the advantage as any other neoadjuvant this one? So it will treat the micrometastasis, it will downstage, downsize. It can assess the in vivo sensitivity of the tumor to the chemotherapy. So RCT and meta-analysis have shown survival benefit for NACT in muscle invasive bladder cancer. So the disadvantage is it can progress while on therapy. There will be increased complication after neoadjuvant therapy, surgical complication. Response evaluation is clinical, not pathological. So all patients might not tolerate cisplatin-based chemotherapy. So what are the trials for neoadjuvant therapy? So Grossman et al. Here they have used different regimens for neoadjuvant. So the preferred one is DD-MVAC. The other one is Gemcis 4 cycles. So okay. In Gross et al. Trial, they have used neoadjuvant with compared with radical cystectomy. So I have not read these trials. I don't know. I can just name them. Grossman et al.
You teach topic na, trials will see.
Grossman, Nordic trial 1 and 2, and Vesper. Vesper is DD-MVAC.
With evidence, I think उसका आया है, that triple modality treatment का आया है, और bladder preservation protocol है ना वो, उसका with evidence आया है I think.
So non-muscle invasive, you just get it summarized in this one chart. Here you will do initial TURBT. Then if there is concomitant CIS which you have taken but it was existing, high-grade tumors, large tumors, piecemeal resections, then you will do repeat TURBT after 6 weeks, 3 to 6 weeks. After that, now you have got your histology, you have your cytological cystoscopy findings, and you will divide them into low risk, intermediate, and high risk. Papillary, non-invasive, low malignant potential one with unknown malignant potential lesions, and solitary TAs with less than 3 centimeter, all of it are low grade. In them, you will give one instillation of immediate mitomycin. Then there is no role for induction BCG in that, and you will just do surveillance for them. So in low risk, you will do TURBT, you will give intravesical chemotherapy, one injection, then you will put them into surveillance. Then coming to intermediate risk. What are the intermediate risk? If the same T1 becomes high grade, then it is intermediate. If it is invasion of lamina propria, or the tumor is more than centimeter, or it is multifocal, but all of it is low grade, then it is intermediate. In them, you will do TURBT. You can give one dose of intravesical chemotherapy. After 3 to 4 weeks, you will give them induction, and you will give maintenance BCG. The interval of maintenance BCG is the only difference between high risk and intermediate. In maintenance BCG, it is 1 year in intermediate risk, 3 years in high risk. So what all constitute high risk? T1 grade 3s, all CIS, all multifocal plus more than 3 centimeter, all of this. If they have a combination of high risk factors, it all come in high risk group, like high grade T1, T1 with CIS, more than 3 centimeter multifocal, and recurrent. So they have a high risk of recurrence and progression. In them, you will give induction BCG, that is weekly 6 instillation, followed by maintenance 3 monthly for 3 years. There is role for immediate cystectomy in high risk individuals, where and all it is indicated, where immediate cystectomy is extensive carcinoma in situ. Even after TURB, you are not getting margin. And if they are BCG unresponsive, this can have intolerance to BCG, or they are refractory to BCG, or they are resistant to BCG, then you will resort to cystectomy. So, what they have asked.
तो BCG अनरिस्पॉन्सिव देखने के लिए टाइम चाहिए होगा ना, कितना टाइम में पता चलेगा कि ये BCG अनरिस्पॉन्सिव है?
I'm defining this. BCG failure has 4 categories. So, BCG patient can be intolerant to BCG. That means they have a lot of side effects. There are different grades of BCG associated toxicity. So they just can present as only some UTI symptoms. They can have concomitant fever, which is not resolving even after stopping BCG. As bad as having pulmonary tuberculosis, which needs anti-tubercular treatment. So they are intolerant. In them, you will resort to cystectomy. Refractory meaning you will start them on induction. After 2 consecutive cycles also, they are not responding. Or after finishing induction, when you do cystoscopy, they have still persisting, or they have progressed than the previous baseline size. So they are refractory. Resistant is when you did cystoscopy after giving induction, they had responded but not completely. It was persisting but lesser grade, lesser size, but after finishing when you did, they had progress, so they are resistant. Relapsing is after they have completed their induction maintenance, you did cystoscopy, it had completely vanished. In their surveillance, you picked up their lesion. So that is called BCG relapsing. So for BCG refractory, you will do immediate cystectomy. What are the other regimens that you will follow for BCG refractory? You can again re-challenge with BCG, but you will add some other form of therapy, like you will add interferon, or you will give a combination of docetaxel and gemcitabine intravesical instead of BCG. You can give valrubicin, gemcitabine, and docetaxel. So the question there is BCG refractory, for which you will have to define BCG refractory. Options are cystectomy. Non-cystectomy options are with BCG you will add another therapy and give, and there is role for intravesical combination chemotherapy, that is gemcitabine and docetaxel. Pembrolizumab is also approved as an indication for refractory non-muscle invasive bladder cancer. So How it is given, I'm not sure. So what are the indications for upfront cystectomy? High grade T1, tumor size more than 3 centimeter, concomitant CIS, concomitant carcinoma in situ, deep lamina propria invasion, LVI. So they have high risk of progressive disease. In them, early cystectomy is indicated. Coming to
हाई रिस्क NMIBC का एक बार प्लीज रिपीट करना ना, ऊपर वाला फ्लो चार्ट.
this one.
हाँ, this.
So you patient suspected with bladder cancer.
This is initial TURBT जिसमें NMIBC आया, and then you do a TURBT. उस repeat TURBT पे you stage low, high or intermediate risk, बराबर ना?
Correct. See, for example, most of the time re-TURBT is advocated, especially you did initial TURBT and you get anything that says high grade or any high risk feature like more than 3 centimeter, you got CIS component along and initial TURBT was not one go, you removed it like piecemeal, you did multiple shavings and you removed. In all of it, TURBT is recommended. To tell it in short, most of the time you'll do TURBT except when you remove the lesion one shot and this lesion was less than 3 centimeter and it was a low grade. And you had even muscle also well made out. In that you can avoid, but all practical purposes we usually repeat TURBT. So you repeated TURBT. After by 6 weeks you repeated TURBT. Then you have what all information you have about the grade. You will see whether it is low. By initial TURBT you saw the size also. How do you know how deep it is, 1 or 2? Muscle included in the specimen they checked and there was no evidence of invasion. So T2 was ruled out and it became less than T1. If it was lamina propria, it was T1A. Or if it is not breached the basement membrane, it is TA. So you got to know it is high grade or low grade. You got to know the size. You got to know the depth of invasion. And you also know the concomitant CIS. If by cystoscopy there is red velvety appearance everywhere, or in your specimen also you found focal CIS or there was extensive CIS. Now with all this information you will grade them. To tell them low risk, you have to have all of these. In a low grade tumor, it should be single, it should be confined to the basement membrane and less than 3 centimeter. If all of it is there, then it is low risk. If any one of it is also not there, then it becomes to the other risks. Then you will go to next risk category. Even a TA can be intermediate risk, T1 also can be an intermediate risk. TA with a high grade or a more than 3 centimeter or a multifocal, it is an intermediate. Whereas T1 is itself, depth of invasion is lamina propria, which is more than TA. Here your adjuncts, your addition should be all something which is less. For example, low grade, less than 3 centimeter, solitary. Since this is already going towards the muscle, if with lamina propria you have any other risks which will make it more, that is grade 3, more than 3 centimeter, multifocal, CIS, recurrent, then it will become high risk. So what is the difference in treating intermediate and high risk is only maintenance BCG. Why? Because this intermediate and high risk have an increased propensity to progress to higher stages. So you will have to prevent them by doing so. You will increase their immunity by giving BCG so that they don't progress and the immune cells will take care of the disease that will progress. That's one thing. So you will do immediate, in intermediate, you will do TURBT. Then immediately You will give intravesical within 6 hours or 24 hours. 6 hours has got benefit. It can be mitomycin chemotherapy. You will give intravesical chemotherapy. Now, mitomycin preferred over gemcitabine. Next, after you finish, you call the patient again after 3 to 4 weeks because you want the mucosa to heal well before giving BCG. Then you will give BCG. You will start making induction doses. How do you give induction? So the dosage is 60, 80, 120. You will choose the dosage. You will give them weekly. You will call them every week. You rule out UTI every time. Before starting, you do your cytology. Urine routine and culture. You will see to that they don't have UTI. Then you will start them on weekly installation of BCG. Then 6 installations will be over. Your induction is over. This is the same for both intermediate and high. Then coming to your maintenance. Maintenance is given 3 monthly. If you give it for 1 year, it'll be in intermediate. For high risk, you will continue for 3 years. Then you will do 3 monthly cystoscopy then on, and you will keep them on follow. What are the deviations from this regular protocol is, if you find too much of CIS, where you know they will definitely progress into muscle invasive, then do cystectomy. If your BCG is not working, one, they are intolerant or they are refractory, do cystectomy. So where else you can resort to, when you yourself as a clinician, you feel this patient has a high propensity to progress, like high grade T1. It is already near lamina propria and it is by grade high. Tumor is already more than 3 centimeter. There is CIS everywhere, and this muscle invasion has gone beyond superficial lamina propria into deep. It's very close to muscle. Or there is lymphovascular invasion where it can spread to the muscle tissue. In all these cases, you can do early cystectomy. Okay. Then coming to
neobladder and bladder.
Neobladder.
आया है ना क्वेश्चन, प्रोसीजर थ्रू ऑफ neobladder?
Is it?
कुछ क्वेश्चन आया तो था.
Not included. I have to go through them. Yeah, muscle invasive, T2 and beyond, N+ disease. So, pathological analysis of tumor depth by invasion on TUR, it's the gold standard. Now you know by TUR-BT that it is muscle invasive, or by imaging MRI local, you found out it is extensive. Then it can be, it is muscle invasive. So T2 and beyond. T2A non-palpable, T2B induration of fat or no masses. This is by examination if you do. This is now obsolete, and we usually resort to cross-sectional imaging with CT or MRI. Then you will, for all muscle invasive, you will add upper urinary tract imaging. So you will find the T stage by MRI. You will know the metastasis by cross-sectional imaging. Then you will do PET CT. You can either do chest, abdomen, pelvis CT, or you can do PET CT for metastasis. Then what are the modalities? If it is an N0 disease, Mama said here is radical cystectomy, prostatectomy, uretrectomy. But usually more than T2, we will give neoadjuvant. Just a second. neoadjuvant cisplatin-based chemotherapy followed by cystectomy. In T2 and beyond, one, you can do cystectomy or you can resort to bladder preservation protocols. If it is cystectomy, it is NACT followed by radical cystectomy. In bladder preservation protocol, it can be single modality or it can be multimodality. Bladder preservation, there are some prerequisites. By patient factor, if the patient is not willing, not fit for cystectomy because the mortality is about 8 to 10%. If the patient is not willing, not fit, frail, by bladder, the function should be intact. If the patient is already incontinent, there is lot of neurological problems, then there is no use of preserving the bladder. So bladder function should be intact. Then the other things with that is there are some soft markers for advanced disease in which you will prior only know that this patient is not going to respond fully to any of your non-surgical modalities. If that is there, for in that what they have given is lymph nodal involvement. If there is hydrouretronephrosis, it is very near to your trigone of the bladder, it is in vicinity to your ureteric orifice. In all of these, most of the time your bladder preservation protocols will not work, and you will have to give them some cisplatin based therapy, which is difficult for the patient to tolerate. In them, you will not use multimodality, you can use single modality, but the survival is not as effective as multimodality. So when now you think you want to do radical cystoprostatectomy, usually it is radical cystectomy until and unless it is involving the bladder neck, the prostate or the urethral margin is positive. In all of this, you will do cystoprostatectomy, or there is CIS concomitant near the neck of the bladder. Then in females, you will remove anterior cuff of vagina and urethra because of same lymphatic supply. Then you will do bilateral lymph node dissection. Then PLND is you will remove all the first echelon nodes, that is hope. Then the second echelon is extended surgery. If you go beyond common iliac, para-aortic, inter-aortocaval and paracaval, by evidences, extended lymphadenectomy has no, or it has got same benefit as your limited lymphadenectomy with recurrence-free survival, cancer-specific overall, or but the mortality, the morbidity of extended is higher than limited. Then coming to, we'll finish off the bladder preservation protocols and then we will come to so bladder preservation. Optimal candidate who are, meaning they are unfit for surgery, they have a good bladder function, they have the tumor is completely resected endoscopically, small tumors with limited CIS, no evidence of hydrouretronephrosis. Suboptimal patient is T3 disease, hydronephrosis, CIS, multifocal R1 resection. These are all soft markers to tell that your CTRT will leave some residual and you will end up doing cystectomy and they will not go fulfilling the bladder preservation protocol. So there are two ways of doing this. It can be single modality or it can be multimodality. So the components of multimodality are individually given without adding any adjuvant, then it becomes single modality. Here, radical TURBT. Here, if you can remove in TURBT full maximally, you can remove everything. You can do it as a monotherapy. Here, what are the strict criteria? Here, it should be after you do TURBT, there should no be any residual disease, no hydronephrosis. There should be N0, tumor size should be less than 3 centimeter, multifocality should be absent, normal EUA, meaning to say there should not be extension like T3 palpable disease, upper urinary tract should be normal, urethral involvement. To summarize, it should be a very locally confined without causing any signs of infiltration either to the ureter or to the tissue surrounding the bladder, or there should not be any nodal spread. In these cases, you can do monotherapy. So if CIS is found at the time of TUR, then you will treat it also. You will do wide excision of that also. Then you will resort the patient to surveillance 3 monthly, thereafter 6 monthly. Then with again selected disease, you still can preserve the bladder by doing partial cystectomy. What are the indications of partial cystectomy? There should be a small solitary tumor amenable to wide excision of 2 centimeter margin, especially when they are located at the bladder dome. They should be well away from the ureteral center, no involvement of neck or trigone, no evidence of CIS. So, dome located small less than 2 centimeter, because you have to give another 2 centimeter to for them, and their location is at the dome. There should not be involvement of trigone or the neck of the bladder. So the trigone or the neck of the bladder is not involved. Okay. Trigone or the neck of the bladder is not involved. There is no hydronephrosis. There is no CIS. So there are no other high risk features. This is mainly done for urachal adenocarcinoma or any dome location tumors. Monotherapy by EBRT. It is especially done as a palliative setting. If it is done in curative, it should be done by IMRT or IGRT, one to deliver better doses and reduce the side effects. Here, similar to your transurethral resection, it should not be a multifocal disease, no hydroureteronephrosis or higher stage disease should not be present. In palliative setting, it is usually done in palliative setting. Monotherapy by EBRT, they don't have much advantage like monotherapy TURP or TURBT or cystectomy. Chemotherapy, this is given usually not as a monotherapy, it is usually combined with EBRT only. Then coming to trimodality. Here you are using chemotherapy, you are using radiation mainly. But if they are incomplete responders, they will go for cystectomy. So how do you split your full course of 60 gray? So you have selected a 60 gray to be delivered, 65 delivered to the patient. Now you can give as continuous course where you will finish off your 65 gray together as CTRT. Then you will wait for 4 weeks, see the response for 3 months, see the response fully. If they have responded fully, it is only surveillance. If they have not responded, then you will go for salvage radical cystectomy. In split course, you will assess the biology and you will select the patients early in whom you will do cystectomy. So in that 65, you will split to give 40. First, CTRT. Then you will restage them by cross-sectional imaging and endoscopic evaluation. Then, if they have persistent invasive disease, you will do radical cystectomy. If they have complete response, then you will give remaining consolidative chemoradiation to finish the 65. So mainly all the course, the target volume you will give once for all CTRT, then assess the response. In continuous course, in split course, you will split the radiotherapy dose by fraction, 40 gray once and the remaining 25 to complete your 65. What are the trials? All that the RTOG trials of bladder preservation protocols. There are so many numbers here. Here they have given EBRT with different agents and different fractionation and different sequence. And these are the trials that have been mentioned. So the trimodality treatment increases the probability of intact bladder in 30 to 40% of patients. So I don't know how to remember this trials. So we'll read together only. All are RTOG. So they start from 85 and until 99. So this is one. This is one. Okay. Then in RTOG, all of the trials have RT in them because they are RTOG. So if you start your protocol with EBRT, with cisplatin, then it is 85-12. 5-year overall survival is 52%. 88 to 89. Here they have used MCV, methotrexate, cisplatin, vinblastine, neoadjuvant. Then they have given RT. So NACT followed by RT. So there is no use of NACT in improving overall survival or local control. Then comes beyond 90 trials, that is 95-06. Here, RT fractionation, they have made it twice daily, used along with cisplatin. Here, there was complete response and bladder preservation rate with overall survival of 63%. So, twice daily dose with cisplatin, there was more complete response and bladder preservation. That is 95-06. Then 99-06. Here, you did TURBT. Then you give cisplatin-based hyperfractionation RT, then adjuvant. So RT followed by adjuvant CT. So it is kind of a trimodality therapy only here. So you did TURBT, then you gave CTRT followed by adjuvant CT. Then Massachusetts General Hospital, they also did a trimodality therapy, TURBT followed by EBRT plus or minus adjuvant chemo. So overall, all of the trials have about 50% of overall survival benefit, where 95-06 twice fractionation had more complete responses and bladder preservation. So in about 30 to 40%, by adopting your multimodality treatment, you can preserve the bladder. So what I forgot to tell you in multimodality is first you have to do maximal TURBT. So that is how it becomes multimodality. Maximal TURBT, then you will give CTRT. CTRT can be split or it can be continuous. Continuous course. Split course is 40 plus 25, so 60. After you have done your surgery, urinary diversions, and they've asked about complications associated with urinary diversion. Basically, your urinary diversion can be continent or incontinent. Incontinence, whether you're diverting the urine per abdominal wall or at neobladder, orthotopic, per urethra. In incontinent, which is the bowel that you use to divert the urine. In complications, Devita is mentioned broadly as metabolic, neuromechanical, in pertaining to the peristalsis, and surgical. Surgical can be short term or long term. So, metabolic complications will be electrolyte imbalances, vitamin absorption, bile salt, stone formation. So, you write this chart as all of them will have acidosis with pH of less than 7.3. Then you write jejunum, ileum, colon. First you write what is the pH, that is acidosis. Start from chloremia. Hyper, hypo. Kalemia, hyper, hypo. Hypocalcemia, hypomagnesemia. Just remember for jejunum that it is hypochloremia, hyperkalemia. In rest everything, it is opposite of this. So all will have hypocalcemia, hypomagnesemia, and that is why you have to give supplements. So in jejunum, you will have less chlorine, more of potassium. So in ileum colon, you have to give calcium supplements, you have to give potassium supplements, you have to give bicarbs, you have to give citrate, you have to avoid giving PPIs, then you'll have to maintain their fluid balance. Then, yeah, pretty much this. Then, because of absorption deficiencies, there'll be anemias, vitamin B12 associated. Then bile salt malabsorption, ADEK, osteomalacia, growth retardation, bleeding, dysthesiasis. Then stone formation because of fluid imbalances and calcium. And there'll be reflux, and urine will be more actually acidic, yeah. Now, neuromechanical is the segment of the bowel could have become atonic, or there'll be hyperperistaltic which causes incontinence. Surgical complications. General, which is associated with any pelvic surgery, it can be thrombophlebitis, pulmonary thromboembolism, wound-related complication, pneumonia, atelectasis, cardiac complication. Specific complications can be anastomotic site-related, it can be urine leak, fecal leak, it can be bowel obstruction, there can be pyelonephritis or acute acidosis. Long term, there'll be reflex pyelonephritis, renal failure, stoma related complications. Here also stoma you can write about necrosis. In long term, it can be parastomal hernias, prolapse, intestinal obstruction, ureteral obstruction, strictures, stones, renal failure, and second malignancy. So this is what I was telling you. Maximal TURBT, then you will do split course or single course. You will give 40. You will reassess by imaging and cystoscopy. If there is complete response, then you will give rest 25 and you will do surveillance. If there is partial response, so there is evidence of disease, then you will do immediate salvage cystectomy. If you have given whole of the full course chemoradiation, then you will do cystoscopy, and complete response will do surveillance. This was that new adjuvant. I have not put NCCN. It's been. अच्छा
टेक्निक्स ऑफ ब्लैडर रिसेक्शन एंड रिकंस्ट्रक्शन में था आई थिंक न्यू ब्लैडर, और सिस्टेक्टमी के जो अपने ये इलेक्ट्रोलाइट इम्बैलेंस के साइड इफ़ेक्ट्स हैं वो पूछा था, और मैनेजमेंट आई थिंक।